Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended. So today we will be discussing about an important aspect of cataract surgery, that is controlling the astigmatism. So just performing a cataract surgery, putting in the IOL is not enough. We need to address the critical aspect, that is the astigmatism, so that the patient has least dependency on the spectacles. So there are various ways, and the most popular these days is the toric IOLs, but then the cost factor is a big hindrance. They are pretty expensive and not every patient can afford them. So in cases where the astigmatism is not very high, around 1 to 1.5, we can opt for this excellent technique, that is the OCCI, opposite clear corneal incision, wherein the main incision is made over the steep axis and similar incision is then made exactly 180 degrees opposite to the main incision, and doing so the combined additive effect leads to a 0.5 to 0.75 diopters of correction when we are sitting temporal and 0.75 to 1 when we are sitting superior. This can be easily done by surgeons all over the world without the need of very expensive equipments. So this is a 58-year-old lady with an S2 to an S3 density cataract and a 1.25 mm of astigmatism at the 10-degree axis. And now getting along with the direct chop, the probe goes subincisionally deep into the substance of the nucleus, traverses forwards, then this karate chopper goes to the far periphery and is brought towards the probe and then laterally separated. So we get a through and through nice crack. Now again going deep in this heminuclei, getting a good hold, and we get two quadrants. Now rotating the nucleus, and again the trick is to go deep so that we get a good hold, and once we have a good hold then chopping becomes pretty easy. So now we have four quadrants, and now is the time to emulsify. The phaco power is 50, vacuum 400, and the flow rate is 38. We can sub chop these quadrants, and we are emulsifying at the plane of the iris away from the endothelium, and we have managed this one heminuclei. So now is the time to come out and again replenish the OVD, coating the endothelium, and now is the time to deal with this other heminuclei. So now I have pulled up this heminuclei out of the bag and then slowly trying to emulsify it. These small air bubbles are distracting, but as they are at one corner, I was able to visualize it nicely, so I decided to continue with my phaco emulsification. And the nucleus is emulsified, and now is the time to deal with this thick epinuclear sheet. Trying to rotate this epinuclear sheet and trying to flip it over so that it's easier to emulsify. So now with vacuum, trying to lift it up. So you can see that most of the work is being done by the dialer, all the peripheral dialing and all, and the phaco probe stays in the central safe zone. Only when I intend to lift this capsule, I'm going to the edge, applying a bit of vacuum, and here it comes and flips over. So if these bubbles are very distracting, you can remove them with the help of a viscoelastic substance. Just push it anterior to them and press the lower lip of the main wound, and these bubbles will come out. And once you have a clear view, you can proceed with the surgery. Now cleaning up the cortex with this bimanual irrigation aspiration by Oatley. It's an excellent tool as it's very safe and it gives us access to complete 360 degrees. And thus, without distorting too much of the wound and risking the capsule, we are able to manage the cortex. And now is the time to switch hands and clean up the other half of the cortex. So catching hold at the anterior rim of the cortex and pulling it towards the center, keeping a close eye at the anterior capsular rim so that I don't catch hold of it and cause a dialysis. And that's it. We have managed the cortex, and now is the time to inject the IOL. The bag is filled with the OVD and wound assisted. Delivery is being done. The anterior haptic goes in the bag and the trailing haptic is dialed in. Now again this chamber is filled with a bit of OVD, and now is the time to do the opposite clear corneal incision with this 2.8 mm keratome. An incision is made and that's it. Now because we have not entered through this incision and not used it, there is no need to hydrate it also. Now the OVD is being cleaned thoroughly from behind the IOL and above to prevent any post-operative IOP spikes. Give a quick visual recovery to the patient. And that's it. Now the wounds are being hydrated. So the take-home message is, do take care of the astigmatic part of the cataract surgery so that the dependency of the patients on spectacle is low. I hope you like this video. Thanks for watching.